Welcome to Endo Club Spring 2017. Here we'll be showing you a patient with suspected early carcinoma in the gastric body, fundus. A 71-year-old patient. Last December, a polypoid adenocarcinoma was found. As you can see, it was already recognized relatively early, but the histology was negative, and the polyp disappeared, so quite an interesting story. But now there's an adenocarcinoma. Helmut, can you show us the findings? And this is it. Actually a lesion. But you think, uh-oh, it's ulcerating. In terms of size, it's certainly, well, we can't see the full extent here, but it's borderline, possibly with submucosal infiltration. We don't know that yet. This is a, look. When you look at it underwater, the pit pattern's destroyed. There's no regular vascular architecture to be seen. So really, a lesion where you have to assume it goes quite deep. I've started at the margin. Here, it's been marked a bit. As I said, I would use a margin of 1 centimeter with this lesion, so you can get into the submucosal layer cleanly. Is that a bit of adenoma as well? Or no? If anything, metaplasia. Open. I'll go in a bit closer. Out again, please. Now point. Further, further. Stop. So at the bottom now, there's musculature. For those that aren't so familiar with it, where it's lighter. At the top is, as it were, the reverse side of our specimen. And I'm positioned here at the clip, as you can see. The so-called clip and line method. And when you put some weight on it, you can see that it goes in better underneath. Now we ought to be able to get in. Here, there's the site. Can you see it? Yes, indeed. You can see it very well. And this, of course, is where you say, is it really due to the size, or point? There it is. You can see. Now it's easier. There, it's blue again. Point. Then you feel comfortable when it's like that. Can you see it? And of course, you have to coagulate all the vessels again and again. Here you can see the vessel well. Helmut, you can see here very nicely how you can use the hook knife to really hook your way into the fibers, so you can work more safely, because the knife is lifted into the lumen each time here. This one site, it will certainly decide whether it's curative or R1, and how deeply it goes in. But it was doable now, I think. We'll accept it like that and wait for the histology. I'm quite excited myself to see how it'll turn out. It would be nice for the patient if it's R0. And if it's a high-risk situation, we'd really have to think about whether a lymph node dissection is really necessary. Histology revealed a G3 carcinoma with deep submucosal infiltration and incomplete basal resection. Further management will involve surgery, with gastrectomy or partial gastrectomy.